my pleasure to introduce the last speaker of this session, Professor Madhu Goyal. She did her graduation and post-graduation from KGMC, and she was lucky enough to start her academic career from same institute. At present, she is in charge of histopathology, cytology, and immunohistochemistry divisions, and she is a recipient of several research awards, including University Excellence Award. She has got more than 150 publications in national and international journals, peer-reviewed journals. And she actively participates in various workshops, national and international conferences, and many of which I have witnessed to. Research interest other than this topic, oral, breast, and endocrinal cancers, also molecular pathology. We all welcome Professor Madhu Goyal for next session. Mike, please.
So after such a heavy session on screening and molecular biology in lung cancer, I'll just be taking you a very short journey of non-gynae LBC, because we have been speaking of LBC so many times, but mostly we prefer it in gynae pathology, and we don't do it in routine in non-gynae cytology. And just for a disclaimer, say I am a user of SurePath for last 5 years, but I have no financial interest with BT, as my institution is a government-aided institution. So main objective is to compare results of reporting on conventional cytology smears versus liquid-based cytology in non-gynae cytology samples, both fine needle aspirates and fluids. And I'll just show you some pictures. No theory, no tables, our experience with non-gynae cytology. Initial experience was a maiden experience of 2 years, where we did 230 samples, 190 FNA and 40 fluid specimens. Our experience was that time conventional smear performed better in FNA cases. LBC was better in fluids, particularly urine. LBC did not have any advantage over conventional smear as far as morphological findings were concerned. So although LBC smears were cleaner and were less time consuming, interpretation was much easier in conventional than in LBC smears when seen independently without the knowledge of either the conventional smear or LBC smear. So this small work was presented in Paris conference. Both the techniques appeared diagnostically reliable. It was too early to comment on which technique was better. Also, the techniques and interpretation acquired appeared dependent on individual reporting cytologists. So now in last 5 years, we have done a total of 1271 specimens. In adults, around 1200 cases, and in pediatric cases, they are around 52 from various sites. Now, believe me that these are not done in routine cases. These are all done as a part of our MD students' thesis, and we have collected these specimens during last 5 years. So I'll take you to briefly to the different sites. Maximum specimens which we receive in cytology laboratory are lymph node. So we received around 344 specimens, of which the major portion was benign, 201, and malignant 131, and inadequate were 13. So just if you see, say this is a conventional smear of you can see a granuloma, and this is a LBC smear. Now this is showing granuloma, but it is not that clear as you can see in the conventional smear. Another case, you can see there is a case of Hodgkin's lymphoma. The top panel shows in conventional, and the lower one shows Hodgkin's lymphoma in LBC smear. In this picture, the LBC appears better. Another case, non-Hodgkin's lymphoma, anaplastic glass cell with cleaved nuclei. The green one is LBC, the pink one is conventional smear, and you can see LCA has come beautifully positive in the LBC smear. Another case in conventional cytology is squamous cell carcinoma on the top, and on the bottom you can see a clear-cut squamous cell carcinoma in LBC. So it is, both ways it is equally good. So diagnosis-wise, LBC was equivalent to conventional smear cytology, but however, ease of interpretation was better with conventional. This is my institution at Saraswati Puja. Then salivary gland tumors, 64 cases, 48 were benign, out of which 47 were pleomorphic adenomas, and 1 was Walden's tumor, and 16 malignant, of which 11 were mucoepidermoid carcinomas. If you see, this is a case from ethnic cell carcinoma in conventional as well as in LBC. They are looking equally good. A case of pleomorphic adenoma again in conventional, and you can easily make a diagnosis in conventional as well as in LBC. So why to go for LBC for such an expensive technique as compared to the conventional? Another case of mucoepidermoid carcinoma, both are equally we are equally comfortable in LBC as well as conventional cytology. So again, in salivary gland tumors, LBC could be compared with the conventional cytology. Bone tumor, 12 cases. This case I showed, I think, those who were present in Gorakhpur also. And this was a 27-year male, restricted movement on right elbow joint. X-ray showed an aggressive permeative destructive lesion in the metaphysis of the radius. And this was the cytology. The top panel shows conventional cytology, looks like a small round cell tumor. And in LBC, you can see the similar morphology, but conventional cytology appears better. And LBC, again, you can see three-dimensional. This is another case of osteogenic sarcoma, and where you can see the conventional cytology looks better, because LBC there is shrinkage of cells. So if you're not accustomed to looking at the LBC smears, you may not recognize. Another case, you can see on the left side is the conventional smear, and FNA done LBC, and S100 is beautifully positive on LBC smear. This is a bone aspirate. Any guess? Histology, it shows osteoid as well as some chondroid with malignant cells. So this was a case of chondroblastic osteosarcoma. So LBC and conventional cytology were equally good, but again ease of interpretation was better in conventional cytology. Maybe it is because of our learning curve, or we are not used to see LBC so frequently in non-gynae cytology. Another example of a bone tumor, giant cell tumor, it is seen equally well both in LBC and conventional smear. So again, our experience with bone tumors was liquid-based cytology was equally good as compared to conventional cytology. This is my institution, an aerial view. Now, the next category was pediatric tumors, 52 cases. In this category, I will emphasize that LBC was better than conventional in 21 cases. LBC was equivalent to conventional smear in 10 cases, and LBC was better, conventional was better than liquid-based cytology in 6 cases. And there was no inadequate sample in LBC. So this was statistically significant. I show you this example of a 1-year-old child presented with proptosis left eye and temporal swelling for 1 month. There was a hard swelling, you can see here. And FNAC showed a small round cell tumor and some amount of it's fine, I can use this. So you can see neuropil. I'll have to see there, no? That screen is not visible. So I'll do it. And NSE was done on this, and this is positive. So this was a case of metastatic neuroblastoma. Another case, so this was metastasis from neuroblastoma. And then a 3-year-old child presented with white pupillary reflex with diminution of vision in right eye for a year and no history of trauma or pain. And CT scan showed a mass here. 0.5 ml of hazy vitreous was aspirated, part of which was transferred to LBC Shorpath vial, and conventional cytology, cell block and LBC smears were made. Now you look at LBC, it was a very cellular smear, and cell block again showed a small round cell tumor, and this was the state of affairs in conventional smear, where we could see only occasional cells which looked like lymphocytes, so it was reported as inadequate or inconclusive. On cell block, NSC was done, synaptophysin was done on LBC smear, both were strongly positive. So this was a case of retinoblastoma with vitreous involvement. Diagnosis was made on LBC smear, reported negative on conventional smear, few inflammatory cells only. And this is important because vision is non-restorable, essential to diagnose to predict the salvage of vision. So LBC here was better in this case as compared to the conventional cytology. So diagnosis was based on conventional smears, but the surgeon insisted. So fortunately, because the girl was doing an MD thesis, so this specimen was kept in LBC smear. So LBC picked up the tumor seedings, and additional smears could be used for immunocytochemistry. Now, one word of caution, additional smears we can make with LBC, but they are not cost effective as far as our setup is concerned, because every time when you make an additional smear, the whole machine has to be run. Another case, a 16-month-old male presented with loosening of teeth, and this is the LBC smear. And you can see pale vesicular nuclei, you can see Langerhans cells. So this was a clear-cut case of Langerhans cell histiocytosis, where you can see coffee bean nuclei and the cells, and these were quite cellular, and CD1A and S100 were positive on LVC smears in this case. So this was a case of Langerhans cell histiocytosis. In this case, conventional and LBC smears were equally informative as far as morphological diagnosis was concerned, but level of comfort was more with conventional smears, might be because of the early learning curve for reporting on LBC smears. Then a word about pediatric abdominal masses out of those 52 cases, where we had 8 Wilms tumor, 2 germ cell tumors, neuroblastomas, and there were inadequate samples 7. And this is a case of nephroblastoma. On the left side, it is LBC smear, where you can see the blastemal as well as the epithelial component. And similarly, in the conventional smear, you can see beautiful blastemal and epithelial elements. This is histology. Another case, yolk sac tumor. Again, ease of interpretation was more with conventional cytology. You can see large malignant cells with pale vacuolated cytoplasm. The cluster in this field is quite solid cluster, so morphology is not clear, whereas morphology is much more clear in LBC. But if you look at the whole smear, again the ease of interpretation was more with conventional. Now coming to the most important area where you may require LBC, and because the specimen is precious, so in lung and mediastinal masses, we did FNA in 82 cases and compared LBC versus conventional. And this has been the first non-gynecological application of LBC in literature. Not mine, the respiratory exfoliative cytology. In respiratory exfoliative cytology, liquid-based LBC displays superior presentation, higher cell yield, homogeneously distributed diagnostic cells devoid of or with minimal mucus, cell debris, and inflammatory cells. So this was the details of the cases. There were 21 benign cases, mostly tuberculosis and inflammations, and malignant 61 cases, whereas the adenocarcinoma was on the top of the list with other tumors which Dr. Rajvanshi has just enumerated. And this is an example of LBC and conventional. LBC on left. All green smears are LBC and other smears are conventional. So you can see a clear-cut example of, but you can see more clusters in one field in the same 20x in conventional as compared to LBC. So here what we observed that inadequacy was an issue. Inadequacy was more in conventional cytology and as compared to 12 in LBC to 36 in conventional. So liquid-based cytology here was significantly better as compared to conventional smear for diagnosis in aspiration samples for lung and mediastinal mass lesions. Since we are working in an institution, we can afford this, and we advocate that lung and mediastinal masses because the specimen procurement is quite difficult and these are precious specimens. So we can do simultaneous, as Dr. Rajvanshi told you, that we can take conventional smear cytology, LBC as well as biopsy in such cases for further ancillary techniques. So in respiratory or mediastinal cytology, liquid-based cytology was better than conventional cytology. Then breast cytology, we did 239 cases. This is a granulomatous mastitis. This is just an incidental finding of microfilaria. And then in liquid-based cytology, you can see breast abscess very clearly seen in both conventional as well as LBC. This is a picture showing fibroadenoma of breast, tight clusters of ductal cells. Then phylloid tumor in conventional as well as in LBC you could diagnose, but there is some kind of rounding in LBC smears. Then infiltrating ductal carcinomas. In LBC there is fragmentation of necrosis, so that is not seen very clearly as it is seen in conventional. Again, there is spindling of the tumor cells in LBC, which is not seen in IDC in conventional smears. Then you can see in, on the left side, you can see cell in cell, and you can see conventional cytology of breast carcinoma. So if you see here, the green part, conventional is better than LBC, maximum cases, and ease of interpretation, diagnostic efficacy, interpretation, cellularity was all in this group was conventional cytology better. In the yellow part, you can see that conventional cytology is equal to liquid-based cytology, but ease of diagnosis is better in conventional. And then only in 47 cases, the LBC was better than conventional. So again, inadequacy. Here, it was just the reverse of mediastinal and respiratory cases. Inadequacy was more in FNA breast in case of LBC as compared to that too in benign, and in malignant again, inadequacy was an issue with LBC. So LBC did not provide any major advantage over conventional cytology as far as breast FNA was considered. Conventional smear method is fast and inexpensive. So basic cost of consumables in LBC is approximately around rupees 350 to 400 without calculation of the hidden costs, to rupees 20 to 15 conventional method only. So this is the basic cost difference. Thyroid LBC is again 274 cases, and here conventional cytology was equivalent to liquid-based cytology. In the upper two pictures, you can see colloid, and you can see a papillary cluster in LBC of a papillary thyroid carcinoma. This is a picture from medullary carcinoma thyroid. I'm not going into the details because you all know this cytology. Last one or two case, this was a female who presented with multiple skull swelling, and this was the picture in cytology. You can jolly well see that these are clear cells. So this was a metastasis of renal cell carcinoma, and CT abdomen revealed the tumor. So this is just an example where conventional is better than LBC. In the top left, conventional cytology of a anaplastic carcinoma thyroid, and similar picture is seen, but you can see that it is easier here than here. But granulomatous lymphadenitis, again, conventional is better here than LBC. Conventional equivalent to LBC, as you have seen in renal cell carcinoma in the upper panel and neuroblastoma mets in the lower panel. Then LBC better than conventional. On the top is a case from plasmacytoma of bone, and the A lower panel shows the adenocarcinoma in pleural. Here the LBC was better than CS. So the idea is that it is very difficult which technique to use where. So our overall outcome, if you see, LBC was better than conventional in respiratory, in fluids, in pediatric masses, and of course, I have not shown gynaecology. Definitely gynaecology is better in LBC. And conventional was better than LBC in soft tissues and lymph node aspirates, and breast also. So advantages of LBC over conventional is that clinicians can use it. The pathologist is free from the needle handling. There is standardized technique, processing. Number of slides examined are less. And most important is that you can use the LBC material for ancillary applications, for cell block, for multiple slides, immunohistochemistry, and good results have been reported for epithelial, lymphoid, neuroendocrine, melanomas, and molecular and prognostic markers. So residual materials can be stored at 4 degrees centigrade, can be effectively used for molecular diagnostic techniques. I'll take 30 seconds only. For RNA, the samples can be used up to 5 months, and for DNA up to 16 months. EGFR, BRAF mutations, HER2 fish can be further exploited for next generation sequencing. So this promotes LBC as a reliable alternative tool to surgical or core needle biopsies in cancer diagnosis, prognosis, and predictions. The biggest advantage is that cytology, you have to scrape the smear. From here you can use the residual material for RNA or DNA. Disadvantages: technical steps induce cellular alterations. Architectural patterns are disrupted with breakage of papillae, cell grouping, or slightly more discohesion. Morphological alterations include shrunken cell and nuclear size. Background materials such as blood, inflammation, necrosis, extracellular elements may impact the accurate interpretation, which we require mostly in the FNAs. Inability to provide immediate on-site assessment for FNA adequacy, and inability to perform tests that require unfixed cellular materials such as flow cytometry or cytogenetics. Undoubtedly, for gynaecology, LBC should replace the convention, as our experience says. For non-gynae, both conventional and LBC are good. So we have to make judicious use of LBC where repeat aspiration is not practical. So guided aspirates, pediatric age group, and fluids, we recommend LBC. It requires experience and familiarity of the artifacts and facts. So there is always a learning curve. The cost of test is a major factor in majority of the instances. So, but benefit will definitely outweigh the cost in time to come, because we are pathologists. We are talking of the cost. Every patient undergoes CT, MRI. So that cost as compared to this cost is very less as compared to that cost. So this is a subjective phenomenon of cost effectivity. I acknowledge my faculty team as well as the residents. The first two, Rohini and Poonam, were the opening batsmen when procured. So Poonam did the non-gynae and Rohini did the gynae. And later on, this was followed by Dr. Sunita, Shruti, Karima, Agarwal, and Singh, Shweta. And now the lymph node part has been completed by Dr. Lavi. So thank you so much. So again, I finish with this quote by William James. So when a thing was new, people said it is not true. When the truth became obvious, people said it is not important. When it's important could not be denied, people said anyway it is not new. So that may stand true for LBC.
Thank you, madam, for giving a very nice, informative overview regarding comparative analysis of LBC and conventional technology in cytology. I'm sure many people who are opting for or thinking of going to LBC part, they'll have very good experience, and she pointed out with nice, subtle
This may be a good
points.
Experience for practitioners, that they don't have to rush for liquid-based cytology.
Very important practical points you have highlighted.
Conventional pap smear is equally good as liquid-based cytology.
Can we go for questions? No comments. Okay.
Now I request the chairpersons to honor our speakers with a memento. Do we have questions?
Anyway, as several delegates want, we can have 1 or 2 questions just before.
Actually, I must congratulate Dr. Madhu Goyal for a large series of cases with LBC comparison with conventional. But I would like to ask Madhu, have you done PEP training in LBC? Then you should do, this is my suggestion. Actually, what? Yes, but I would like to suggest that when you are doing LBC, PEP in LBC, you should do PEP in HE also, conventional also, because it gives a better comparison in both the states.
GIPSA, HNE and PAP.
Yeah. No, but when you compare the slides, then you should compare in the same stain, in same stain. This is my suggestion. You, if possible, compare it the same stain because it gives a better impression. Now, lastly, I would like, before we break for the lunch, I would like to express my heartfelt gratitude to the organizers to organize this big program and to invite me as in this program. And Dr. Ram Nawal, Dr. Manjula Murari, Rakesh Pandey, actually big man behind this show is Dr. Rakesh Pandey, who is sitting at the back. I would like to call him and come on the stage and show his face that he is the big person, main person or organizer. Come on, Rakesh. Rakesh, come on. Rakesh, you have to come and you have to take photograph. Where are the photographers? I'll take photograph with Rakesh. He is the main man who is organizing. And come on.
Sorry.
I request Major General Vibha Datta to present a memento to Dr. Rajan Devar. Professor Vatsala Mishra to present a memento to Professor Arvind Rajvanshi. Sir. Dr. Rani Bansal to present a memento to Professor Madhumati Goyal. I invite Professor Rakesh Pandey to honor our chairpersons. other have shown.
So I have to say a few words. This is not my brainchild. This is primarily Dr. Ram Naval's. I don't want to take any credit from him. It is entirely his show. He has worked very, very hard along with Vinita and other faculty members to bring this to show. Thank you.